Good morning, everyone. My name's Nicole Ampsing. I'm a coach with Lean Enterprise Australia. For those that are joining us from outside Australia, it's 10:30 in the morning here in Melbourne, and I'm really pleased to introduce Jane Evans, the Group Manager of Improvement Experience at St Vincent's Health Australia. And Jane's going to share with us some of the work that she's been doing about waste in healthcare. So I'm hand over to you, Jane. I'm going to drive the slides, so I'll just get set up and then we'll get going.
Thank you, and hello to those of you that are in attendance already. Really pleased to meet you virtually. I just wonder if you could share in the chat for me how many of you are from healthcare and how many are from another industry and what that industry might be. Just be interesting because I think those of you that are in healthcare, I think the messages that we're talking about today will be I think will be quite pertinent, and for those of you that aren't, might be a bit of an eye-opener. So if you can just put in the chat what industry you're from, that would be great. And I will start the conversation while I go, while you're doing that. So this work that I'm going to present to you today is actually part of my doctoral thesis. But I also am the Group Manager of Improvement and Experience at St Vincent's Health Australia and work across the group in our public hospitals, our private hospitals, our care services, and all of the associated parts of driving an organisation as large as St Vincent's. And what I'm going to talk to you about today is how we might think about releasing the opportunity cost of waste in healthcare. Next slide, please, Nicole. Couple of definitions to start. Firstly, an opportunity cost is the opportunities foregone in the choice of one expenditure over others. So when we think about waste, which is any activity or resource in an organisation that does not add value to the customer, the opportunity that we spend on waste and not on other things is very real and a real cost to the organisation and to the health system as a whole. I also just want to talk about value and note that value is the outcomes per dollar spent. And this is a slightly different concept than value-based healthcare, which is, I'm sure all of you are aware of that terminology. I want to talk about the value of care, and value is outcomes per dollar spent. And what we know is that the inverse of value is waste. So there's a couple of different definitions of waste there. Next slide, please. What we know from the literature, and this literature is decades old now and pretty consistent, that 30% of activities and therefore the cost of healthcare is classed as non-value adding or waste. And if we talk about the health system as a whole, the US alone is over $10 trillion. So 30% of that is $3 trillion of wasted expenditure in healthcare. Next slide, please. So a couple of three controversial thoughts is that everyone involved in the delivery of healthcare services is responsible for how much is spent. It's not the responsibility of the finance department alone. Our staff are the people who deliver the care to our patients, both indirect and direct costs, and therefore they are responsible directly for how much is spent. We also know that waste in healthcare, both clinical care and process waste, is endemic. It is everywhere. And that to know the value of that care, you must know the cost of that care. So we are pretty good at measuring outcomes, both clinical and patient outcomes, but we are not good at all at measuring how much we spend. And when we think about waste and where it's endemic, where our staff spend our time is where the waste is. We do tests on patients that are not necessary. We do tests on patients that we don't go back and review the results. We provide a lot of non-evidence-based clinical care and low levels of evidence-based care. We have expensive supplies. We have staff not working to their scope of practice. We have unnecessary motion due to the layout or because of where things are located. We ask the same patients the same information over and over again, wasting their time and the staff's time. We wait for things everywhere. We write reports that are never read. We collect data that is never used. And we have, certainly in our organisation, we have incredible amounts of clinical applications that don't talk to each other and that are not necessarily used to their full scope. Next slide, please. This is a slide that I saw Don Berwick, who is the author of this paper, present in 2012 in Paris. And he made an attempt at taking Taiichi Ohno's 7 wastes and putting them into a healthcare context, and came up with six categories of waste, I guess. Next slide. Next. Yep. And in this paper that was then taken, the information was then taken by a group of clinicians in the US, and they costed the projected cost of waste in each of those buckets, and then used the literature to say, of all of that waste there, how much is potentially able to be saved and reduced. And they came up with nearly $286 billion in 1 year for 1 year's worth of expenditure that could be saved. And in saving that nearly $300 billion, they could fund every single uninsured patient in the US for the healthcare needs, for their healthcare needs. So we have an absolutely huge opportunity to do something about this. Next slide. So do we have a knowing or a doing problem in solving this worldwide problem? And let's just start with the what do we know? Next slide. So what does history tell us? I gave myself a bit of a challenge and looked to see what I could find in the literature around the cost of healthcare. And this quote has come from a journal article that, again, talks about we have no progress being made in regard to the economic aspects of medicine. And I'm sure none of you can guess how old this is, but if you click again, Nicole, this paper was written in 1933. It came from a report of a committee of 200 clinicians in the US that met from 1925 to 1930 and came up with this report on the costs of medical care. So we have a problem that we have known about for at least 90 years that's been published. Next slide. So part of my research has been to actually ask hospital executives from around the world, what do they know about waste in healthcare? And my favourite quote is the top one. A wise person once told me that if you walk through a healthcare system and you learn to see the waste, you'll realise you're swimming in it. It's dripping off the walls. A CEO from one of the other hospitals that participated in my research talked about organisational habit. And at the end of that paragraph says, we've actually locked our people up in the way we work. And in doing so, we are locking them in to 30% waste. So next slide. So here's a simple model. We have a hospital, and hospitals account for 40% of healthcare expenditure. We have a simple model, next, just click again, which says if we can identify the process waste and the clinical waste in what we do every day, we should be able to use improvement methodologies, whatever model you want to use. I'm going to use the term process improvement here to cover all of them. We should be able to apply process improvement to reduce that waste. And then just let's measure and capture the financial impact. Pretty simple? Maybe not so. So this is the framework that I have published as part of my research, and it builds on 2 earlier frameworks that came from the IHI. The first one was in 2006, and they built on that in 2009, and now in 2023, this has been published as the next stage. So step 1, pretty simple, but not so evident in everyday practice, is that we should identify all the quality and experience initiatives that we would aim to reduce the defects in our clinical care systems. And also, we should be identifying the things that reduce waste and operating expenses through the identification of process waste, and pull those together to establish a balanced portfolio of process improvement initiatives. And this is the piece where we really should be looking at using our strategy deployment models to build that balanced portfolio intentionally. And rather than having 1,000 flowers blooming, look at what are we going to work on that's going to give us our best bang for our buck in terms of value. Then the next step is to activate a process improvement and project management system consistently, where we are actually solving these problems and reducing the waste using an evidence-based improvement methodology. The fourth step is that we build a benefits realisation framework that includes financial benefits. What I found from my research is that we often have improvement pieces of work sitting in the finance department that only measure financial outcomes and not the clinical or patient experience or staff wellbeing outcomes. And we have improvement projects sitting in the clinical space that don't measure financial outcomes. So how do we build a single benefits framework that covers all? And then how do we capture them to have a redeployment strategy that actually looks at how do we capture those costs so that we can intentionally apply them to either the bottom line, new systems, new staff, etc. And what are the contributory elements then that will enable this application of this framework? What are the technical, next slide, please. How we actually then bring these to life is through our strategic funnel of all the things that we need to look at. Thank you. What are all the low levels of high value care we're providing that we need to increase? And what are the high levels of low value care that we need to reduce? And where's our process waste? How do we put them into a funnel to have that bipartisan set of initiatives that are going to drive improvement? How do we apply it to each of those, our improvement methodology with a benefits framework? And then how do we collate them at the end to apply at an organisational level? Seems pretty simple, but the next slide actually talks about those contributory factors that actually inhibit or promote us to do these. Next slide, please. So we know lean improvement is a socio-technical system. So I actually divided these contributory elements into both. We have on our technical side, our current financial and accounting systems in healthcare don't support us to actually measure the value of care for our patients. And therefore, we can't measure improvement. We don't have really good clinical costing systems to cost to the patient level. We can really, at best, cost to the DRG level. We don't really have a mature process improvement program that enables its application day in, day out for every change initiative that we do. We don't have a good financial benefits methodology that we can apply to clinical improvements. And we have this extreme administration compliance to meet our government and insurer requirements. So we've got a lot of technical things that we need investment and an intentional investment and building of these technical elements. But on the social side, we actually need to ensure that we have process improvement capability that includes high data literacy. Our ability to understand what to do with the mountains of data that we collect to drive improvement is pretty immature across the board. We need to have rigor and consistency of application of process improvement. We need to have some accountability for expenditure, because at the moment it's nobody's job. Financial literacy is also really lacking. I remember one finance director that I spoke to said, whenever I talk in a meeting about budgets and expenditure and mention EBITDA, which I don't even know what it means, I couldn't tell you what that acronym stands for, every clinician switches off. And yet that is the only language we currently use to talk to our clinicians who spend the money on how they're going financially. We need to set organisational expectations around being rigorous in our application of this framework. And we need to have some discussions with the political and policy environment that really drives a lot of current practice. Next slide, please. So this is strategy deployment on a page. We need to have our improvements efforts focused on strategy goals, and then we need to deploy this annually through the business. We need to employ structured problem solving and or project management for every single change item we bring to the table in our business plans. We need to measure our benefits, and I talk about the quintuple aim plus one. So the quintuple aim being quality, safety and flow, patient experience, staff experience and wellbeing, cost, equity, and the plus one is our environmental sustainability requirements. And finally, we need to collate the benefits across the whole of the organisation to understand its contribution, the contribution of improvement efforts towards our strategic goals and therefore our true north. If we're not doing this, actually, we have no understanding of how our business planning, annual business plans actually contribute to our strategy. Next slide, please. So we seem to have a doing problem. There's lots of knowing about what we're doing. Why do we have a doing problem? And there's actually quite a bit of evidence in the literature. Next slide. And just click on all of these. I won't read them out, but these all come from the literature, from sources that talk to us about why we are not actually tackling waste. I think some of them are pretty clear. Medical staff aren't aware of their role and responsibilities to take action. My favourite one is the top right-hand corner, which is we have yet to develop a sense of embarrassment about the levels of waste. We have lack of evidence of the positive impact of improvement on financial performance at the enterprise level. And I undertook a systematic review and found that absolutely to be the case. And that our health system policy environment doesn't actively support us to remove waste and reduce costs. Next slide, please. So what do I know? We all know this. It's not just me. Everybody knows this. So it is not surprising that our costs in healthcare keep rising because we're actually not really doing anything about it. So what else do I know? We have the will to change the cost of care and improve value, because anytime I talk to people about it, they go, absolutely. We also have ideas on how to do it, because what I have found in the 6 hospitals that I've worked in, all of them have a financially driven improvement program, but they don't apply that to their quality and safety. But we need some further understanding of how to capture and collate the released funds to intentionally reinvest them. And we need an execution plan developed and driven by governments and hospitals in partnership, because there is investment required and there is changes to the policy environment that's needed. And I think that is the last slide. Thank you.
It is. Fantastic. Thanks, Jane. We've got a lot of people here. We've got someone with their hand up. So we might start with Kurt. Kurt, have you got a question for Jane? No, it's gone away. I've got a question, Jane. So fantastic. Thanks very much for the presentation. We saw some other comments in the chat while you were talking that perhaps this issue is not necessarily just exclusive to healthcare. I mean, that's an interesting observation in itself. The question for me is what's your advice or experience about how to start? Because it feels really big. You know, you've got policy, you've got a whole lot of system drivers that are kind of working against you, and some organisations are big and complex. So what's your advice about how to start?
It's a really great question, Nicole, and one I am tackling within my own organisation. I think one of the biggest barriers, I think one of the biggest barriers to starting is acknowledgement that this applies to me. I have had conversations with people, lots of people, and they say, but we're already doing this. Like, it's obvious. Your framework is nothing new. It's obvious we already do this. There's lots of examples of people around the world doing this. And when I try and challenge that, they just say, oh, you know, Mayo's doing it and Cleveland's doing it. And look at Virginia Mason and, oh, Intermountain Health. And, you know, they can point, and Denver. But actually, it's, you know, show me the money. Show me how you got the money. So it's really, and I've really been deliberate about splitting that framework into 4 different sections, because each of them require a different place to start. And whether we start with let's be accountable about doing the improvement, using an improvement methodology. Do we start there? Yes. Do we start with building a benefits framework? So at least we can start to collect a common benefits framework. Or do we start with building that balanced portfolio? And I think there is, you know, it's that usual thing. It doesn't matter where you start, but you've just got to start somewhere. So I'm starting is at the benefits framework, and let's see if we can start to build that and start to show by doing and iterate that with a you know, a group of stakeholders. Your finance teams have to be involved. You have to have clinicians on the ground involved. You have to have your improvement specialists. You need to have your strategy people there. So it's really just starting somewhere.
And also, you know, that conversation there about the broad range of stakeholders you've got is really consistent with lean practice and thinking, isn't it? You know, it's about bringing people together, all of the different perspectives, bring their experience and expertise to the task in a joined up way. So they can all learn from each other and build their understanding. Anastasia says in the Q&A, we should not be embarrassed from the waste everyone has. That's very true. We should consider them as opportunities to improve outcomes. And also she adds there, raise funds to buy new tech, or, you know, reinvest in patient value potentially. Jane.
Absolutely. And I did see Anastasia put something in. This is not just a healthcare problem. There was a really great paper put out in 2021 about exactly this issue in industry. And it was basically, again, did a systematic review and said, this is a massive problem in all of our industry. It was much more focused on a return on investment sort of measurement for lean and improvement teams. But it actually said the same. We don't capture the benefits and the financial benefits of the waste removal. We just assume that improving quality and value will lead to a cost reduction, but we haven't seen it because the cost of care is still going up.
Yes, absolutely. Fantastic. All right. Any other comments or questions about Jane's work, or suggestions for what next?
Challenge me.
That's right.
Can't believe everyone's so quiet.
That's right. That's right. Jane, one of the things that you talked about, of course, is the link between the work that you're doing and the framework that you've developed and strategy deployment. Right, because strategy is about often, well, it's nearly always about making things better, but you know, often it's got a mix of those different elements in it, such as value extraction, saving money, taking waste out. You know, irrespective of whether you're in healthcare or any other industry, you're often looking for more opportunity to create better value and do it more efficiently. So I'm interested to hear your thoughts about, you know, how this model can actually help organisations think about their strategy deployment.
It's a great question, and I think from experience, there is a missing link between strategy and that everyday, daily improvement and you know, that continuous improvement piece. And particularly around strategy deployment and improving quality of care. I think there is an absolute disconnect, and we think we are doing strategy deployment by looking at these, you know, in healthcare, high level flow or, you know, outpatient flow. And yes, but then we've still got this, you know, meadow of flowers blooming at the front line that are absolutely disconnected from, well, how is that work connecting to our true north? And, you know, from experience, you know, what we do is, you know, you want to do an improvement project and you say, which part of our strategy does this link to? and you can make anything fit.
Yes.
But it's not an intentional, yeah, but how is this going to contribute to the outcomes we want from our strategy, not which pillar.
Yeah, how can I hook it up so I can get it done? Yeah.
Absolutely, because everyone is so passionate about making their little piece of the pie better. But it just means that we're all focusing on a million things each, and we're not all focusing on all of those things that are going to drive us to that true north. And I don't necessarily think we're that good at really defining what true north is in healthcare from a patient value perspective. Delivering patient-centered care and putting patients at the centre of their care is not a true north. You can't measure it.
Yeah, I agree. Jan, yeah, absolutely. Jan Rice has put a question in the chat. She says, given that financial benefits are so important and yet talking about financial outcomes doesn't always resonate with clinicians, how do you suggest we have those conversations and present that data?
We don't ask clinicians about what they think their role is and in the expenditure and the cost of the organisation, or how to talk to them. We have never even engaged them. We just, as I said, we engage them in profit and loss statements and these EBITDA things that I still don't know what they are. How would that engage a clinician in understanding how much it's costing to care for the patient in front of them or the resident in front of them? It's so we actually haven't even started that conversation. So the first place to start is go if you know, because I recently presented at the NHS and there was a bunch of clinicians in the room and they all said, talk to us in our language, not in your language. And how do we actually bring languages together and start that, you know, shared decision making around how can we proceed and start? And I know the IHI have done some pilots in this in 5 different places where they're really bringing it at that frontline level, and it's had some great results.
Fantastic. All right, well, we're coming down to the last minute, Jane. So I'm going to give you a couple of seconds to think about any closing comments before I thank everyone. While I thank everyone for coming along to hear about your terrific work, and also for those people who have contributed to the discussion in the Q&A. Thank you. Thank you very much for that. Jane, is there anything that you want to add to close us out?
Not really. I have had only that I've had 3 papers published in the last couple of years. And so if you Google Scholar it, you should be able to find them. 1 is open access and 2 are behind a paywall. But if you want to contact me, I'm very happy to provide you with a copy of those papers. So
fantastic. Fantastic. That's great, Jane. And I'm sure you'd be interested to hear from people who are also interested in the work. All right, terrific. Thanks everyone for coming. Thanks so much, Jane. We really appreciated your time and your presentation, and all the very best with your work.
Thank you.
Take care, everyone. Bye-bye.